On behalf of Kidney Cancer Canada and as a kidney cancer survivor myself, I'd like to thank Dr. Anil Kapoor and Dr. Christian Kollmannsberger for leading us in this discussion on what adjuvant and neoadjuvant therapies are available as options for patients to consider. I am very proud to say that Kidney Cancer Canada has available on our website under the clinical trials section a listing with brief description of adjuvant and neoadjuvant clinical trials currently open to patients across Canada. And it is kept current, and the treatment trials are there as well, and it's kept current by the hard work of our Kidney Cancer Canada Medical Advisory Board, who make sure that we know that a trial is opened in their center, whichever province they're in. I would like to now ask Dr. Kapoor and Dr. Kollmannsberger to give us an update on what is known from the clinical trials that have been conducted and those that are currently open, and maybe more importantly, where's the direction of clinical trials research taking us in the future? This should be a very lively discussion. We have two very heavyweights here in the research world. They're famous, they're quite famous. You see them all over the place at ASCO and in all parts of the world where they do all those wonderful conferences on all the research that's going on in around the world. And so don't kid yourself, they are heavyweights. And I give you a warning that this is a debate. This is a debate because they're not always going to agree, because as in any debate, there are always more questions than there's answers.
Adjuvant treatment, which means treatment given after a complete surgery in order to reduce the risk of recurrence. That's what adjuvant means. We do that in gastric cancer, we do it in breast cancer, we do it in colon cancer, we do it in lung cancer. Often when the tumor is completely resected, the oncologist will come and say, there's data suggesting that with giving you 6 months of chemo, we can reduce, not make it zero, but reduce your risk of recurrence. In kidney cancer, that has never been there. But now with the introduction of all these new agents, a number of studies were done over the last decade, which we are now getting the results from. And the results we will discuss. I think Dr. Kapoor will show a little bit about that. And the results are not so clear-cut as we wish they would be, at least not yet. So there is a lot of debate about these results and whether that should or should not be a standard treatment for patients. One of the problems we have when we discuss adjuvant treatment with patients, irrespective which tumor type we talk about, is that we will never be able to tell the individual patient in front of us, yes, you will or you will not have that benefit, because it's all statistical numbers. And we cannot determine for the individual patient in front of us what their individual risk of recurrence is. If we could do that, that would be ideal. If we could measure something which would tell us this patient is a very high risk for recurrence or this patient has no risk for recurrence, that would help us to distribute that treatment. But in the end of the day, when you give adjuvant treatment, you will overtreat a significant number of patients, so you will give them toxicity for no benefit because they either are cured with the surgery alone or they will have a tumor recurrence irrespective of whether you give or don't give the treatment, and only a smaller portion of patients will actually be cured by the adjuvant treatment. So that's the dilemma we are in, and that's why this kind of treatment, where you get toxicity for potentially no reason, requires a very detailed discussion and understanding between the doctor and the patient.
That's a great summary, Christian. So I'm just going to present some of the data on both our behalf. And then we'll have some discussion about the pros and cons. There's really no pro and con. It's really about what's best for our patients and everybody in the audience. I'm not sure how many people in the audience have had recent surgery and are at high risk for recurrence, but this is what it would apply to now. And also those patients that had surgery in the past that are cured, what the options would have been when you had the discussion with your Uro-Oncologist or your urologist. So it is a debate, but really the debate is who has most hair. And obviously, we know who the winner is there.
You seriously want to take it to that level?
Well,
in here?
I really chose the most flattering picture I could find of you. So And that's where Mr. Google is very handy. I'll just leave that a few more minutes up there because I really like that picture.
That's why you don't need enemies. You just need good friends.
So we had the discussion from Andrew about the patient comes in to their family doctor with a mass in the kidney. They've had some blood in the urine. Then they go see the urologist. And then we work them up with a metastatic workup. And then we often do surgery. So this is a patient that probably wouldn't see Christian unless we referred it to him. And that's some of the discussion that we can have about these kind of patients should be referred now, whereas in the past they were not. So this is a case of a patient of mine who had kidney cancer. And T3, for those that recall the staging, is T1 is when the cancer is less than 7 centimeters. So anything less than 7 centimeters is a T1A, T1B. If the tumor is over 7 centimeters, then it's a T2 or second stage cancer. If it's into the vein or into the renal sinus, that's a more advanced cancer, that's a T3. And if it's into the organs around it or the tissue beyond the kidney, that's a T4. So that's stage 1, 2, 3, and 4. And if it's the N0, M0 stands for the nodes and any metastases. So this was non-metastatic. We removed the left kidney. It was a third T3 tumor, but there was no nodes that were involved, and there was no metastases, so it was non-metastatic. So we would keep that in my clinic, and in the urology clinic or the Uro-Oncology clinic, and traditionally not send that to the medical oncologist, and we would do surgery, and then if surgery part came back clear cell carcinoma, again T3, because it was a third stage tumor, correlates to the initial CT scan, N0, so there's no signs of any spread to the nodes or metastases, and grade 3 means the grade of the tumor. So the way we stage these tumors is the size, which I just talked about, T and M, the T stage, and the grade. This is the aggressiveness of the cells under a microscope, and that's from a Furman grade 1 to 4. So this is a grade 3, which means more aggressive cells and a more advanced stage tumor. And also, we look at sarcomatoid elements in most pathologies, and that's where we have to standardize pathologies across the country, where they look for these sarcomatoid elements, and not all pathologists do that. So part of the healthcare team is actually the pathologist. We need them to do a good job standardizing pathology so that we can interpret these kind of results. So this one had 25 sarcomatoid, which is an aggressive variant of clear cell. So his risk of reoccurrence when he comes into my office is about 50%. So I quote him, 50% chance this cancer is going to metastasize in 5 years. And every patient says, well, what can I do, doc? How can I do this? And I just tell them to stay healthy, exercise, don't eat anything that tastes good because it's probably not good for you, and try and do whatever you can to stay healthy. And then the role, is there any drug I can give them to prevent their risk for reoccurrence? And that's the debate today, and it's controversial, and I'm going to go into the data briefly about what this is. This slide just tells you in the bars there, the risk for reoccurrence. And so if you see the T3s and T4s, this is out of a Swedish registry showing that 40 to 50% of these patients with T3, T4 disease will have reoccurrence in 5 years. That's a summary from the middle bar there, is that when we see patients with these larger tumors or into the vein, that their risk of reoccurrence is pretty significant. So if it's an early stage T1 or T2, then the risk of reoccurrence is 20% or less. And so those are the ones that we target in terms of low risk, intermediate risk, high risk, and very high risk. And you use that nomenclature with the medical oncologist and the informed urologist that we'll standardize those pathologies into the risk of reoccurrence. And what we're talking about is the very high risk or very high risk for recurrence patient that we want to help. So ideally, it's a drug that has a high risk of recurrence that we want to target. We don't want to give somebody who has a 3-centimeter mass any of these drugs because there's no advantage to that because the risk of reoccurrence is less than 5%. So there's no reason to go on a drug if you have a 3 or 4 centimeter tumor that's been removed. So these are the trials, and again, I'm just going to present one slide on each of them so you don't get data overload. But the last 4 are the key trials, the ASSURE trial. And I'll repeat this a few times so that you can understand the issues here. This is a randomized controlled trial in patients who had their kidney cancer removed that were randomized to sunitinib, standard dosing, sorafenib, standard dosing, or Nexavar, or a placebo. And the S-track was a similar population, but these were patients that are high risk for recurrence. And the ATLAS trial was adjuvant axitinib, which is just released last week or a few weeks ago, which is a negative trial. And the PROTECT trial was adjuvant pazopanib or Votrient, which is also a negative trial. Of these 5 trials here, 4 were negative, and the middle one, adjuvant sunitinib, was positive. So then how do we decide how to best advise our patients? On a one slide, looking at the ASSURE trial, this is randomizing those 2 drugs I talked about, Sutent and sorafenib and placebo. It was negative. In fact, the patients on placebo had less chance of their cancer coming back than if you're on sorafenib or sunitinib, which was distressing that placebo did better than the drugs. Now the S-track, the middle slide, showed that there was an advantage in terms of disease-free survival. That means there was an advantage to prevent the cancer coming back over a year if you took sunitinib over placebo. And the PROTECT trial, at the end there was an adjuvant pazopanib, which was a negative trial as well. So the summary there is that the 1 positive, 2 negative trials, and the FDA in the US has approved sunitinib in this patient population. Patients that have their surgery at high risk or very high risk have this drug approved to offer patients to take sunitinib. In Canada, we don't have approval as yet, and it's doubtful whether we will get it, but we're still waiting for Health Canada to look into this data. It's been on their desk for a year or so now, and like most government agencies, they take a lot of years to do anything. But we're waiting for the Health Canada to make a decision. This is an important slide in terms of the patients that we looked at in the ASSURE trial. And in terms of the debate, if you look at what it says PT1B, I discussed the staging at the beginning. PT1B are tumors that are 7 centimeters or so, and grade 3 to 4. So these are not just high risk, these are called intermediate risk. So the patient that comes to me that's had a 7-centimeter tumor removed, grade 3, that's not a very high risk for recurrence patient. The risk of recurrence is 20%, but they included it in the trial, and that may have been not the best thing to include because, again, it was negative for those patients, but the high-risk patients benefited more. And then this is the slide showing that there was no overall survival for all 3 arms, and in fact, the placebo had a disease-free survival of 6.6 versus 6.1 versus 5.8 years. So negative trial. On the S-track, if you look at the inclusion here, on the left-hand side, these are T3, T4. So these are patients who had advanced stage and size of tumor and a higher grade. So these are a purely high-risk population that randomized, and they actually benefited. This shows a slide that at a follow-up of 5 years, there's a year advantage to the disease-free survival. So the cancer came back a year later if you were on sunitinib than if you didn't take it. Now what Christian's going to say is that the overall survival is not different. So in fact, even though you did have a disease-free survival, which is a primary endpoint, and delayed the onset of the cancer coming a year, the overall survival was the same. That means patients in both arms, the placebo and the sunitinib, lived exactly the same length of time. So that's the controversy in a nutshell in this one slide, really. They did have a longer duration of DFS, 6.8 versus 5.6, and the overall survival is pending but looks negative. I think I'll skip over that in terms of the debate on this. And then the last trial is a PROTECT trial, and this was pazopanib, 800 milligrams, which is otherwise known as Votrient. And also at 2 dosings. Pazopanib is 4 pills of 200 milligrams. And so this looked at 600 milligram dosage, or 3 pills. And they also had a dose of 800 milligrams. And the 600 milligram dosing, it was a negative trial. And the disease-free survival was the same for both of those. But you can see the 800 milligrams actually had a little bit of an advantage. So what we're summarizing from these trials is that the more drug you can get into the patient in a high-risk population, the more advantage you're going to have. But it's at the expense of some toxicity, because these drugs, as you know, have a lot of, we talked some of the earlier in the day, that these drugs have a fair amount of toxicities that we have to manage. So just to summarize those 4 trials, the S-track, which is the positive trial, which showed a benefit, was a high-risk population, T3, T4. The PROTECT trial, the ASSURE trial, and the Uro-Oncologist trial were all intermediate and high-risk population, T2s, as well as the T3s and T4s. Now, that may be the difference. So that's our controversy now, and we're trying to sort through what to offer our patients, and I think it's important to offer adjuvant sunitinib as an option. And the first thing we should offer patients, like anybody in the audience, is a clinical trial. So we have a number of adjuvant clinical trials that are offered. There's 4 of them being offered in Canada. And this is the Adjuvant Emotion trial, which is adjuvant atezolizumab versus placebo. And this is an IV Immuno-Oncology drug that you can take for up to a year after surgery compared to an IV placebo, and we'll see if that makes a difference. And perhaps the Immuno-Oncology drug may have more benefit than a TKI like sunitinib or pazopanib or so on. We also are looking to open the PROSPER trial, which is a neoadjuvant and adjuvant nivolumab drug, and this also may be of some good benefit to patients to have the drug in their system before surgery, and we're hoping to open up that trial soon. And Kidney Cancer Canada and many of us are advocating to get this trial out as soon as possible. It's open in the US, and we really want to open this up in Canada as soon as we can. So this is just a comparison of the 2 trials. This will be on the website afterwards. You can compare the 2 trials. But these are both excellent trials to enroll in to see if this can benefit getting an adjuvant IO drug. Again, there's 2 other trials. I think Christian's offering the adjuvant nivolumab and IPI trial at his center, and there's also the adjuvant pembrolizumab trial that we're going to open up in Hamilton. So it's 4 options for clinical trials after surgery, which is what we would encourage first. But in the absence of a trial, or if you're ineligible for a trial, I feel strongly that we should offer adjuvant sunitinib to that high-risk patient because of the DFS advantage. So this is the summary showing that the DFS is positive in one trial but negative in other trials. I think the first thing is to enroll in clinical trials. And my second last slide will be another patient scenario of a patient of mine that I saw, a 38-year-old family doctor. He's got 2 children, aged 5 and 6, a very young man. And he incidentally had some blood in his urine. We're going to send him for some genetic testing with the Raymond Kim because he's under the age of 45. He had a 10-centimeter mass of his kidney. Again, this is another T3B advanced cancer into the renal vein, grade 3 out of 4. I discussed with him when he sat in my office. I said, you have a 50% chance of this cancer coming back in 5 years. He's like, you've got to do something for me, doctor. I'm not willing. I did discuss with him that we don't have any overall survival, which I have adjuvant sunitinib, but I did give him the data, and he chose to take the sunitinib, and he's actually on it, and he's doing well. He's in a negative CAT scan so far, and he's in Club Med, and he's given me a bottle of wine with every CAT scan, so I'm very lucky. So my last slide is that I think patients should have a discussion regarding the option of adjuvant sunitinib or clinical trial enrollment with the medical oncologist. I think the uro-oncologist or the urologist after the surgery should at least discuss it briefly with their patient, saying we need to discuss adjuvant therapy. The medical oncologist is the one that should administer it, and the motivated patient may choose to take this if they understand the pros and cons. My 38-year-old family doctor is having some side effects of this. He's having some hand and foot rash. He's able to do his job, but he's not happy, but he's taking it because he's motivated to do so. Thank you.
So, any rebuttal to that?
I don't think our opinions are so far apart. What I would like to emphasize, even more than in the metastatic setting, I think in the adjuvant setting, given the current situation with the data, it is really of utmost importance that the patient understands what we are doing so that the expectations and what we can achieve with that treatment is really clear. The primary objective of adjuvant treatment in oncology is usually that you prolong the survival of patients, that you cure more patients. That's really what we want to do when we give chemotherapy in any form after a complete surgery. From the data we have so far, we cannot achieve that at the present time in kidney cancer. What we can achieve is that if a patient takes a year, if a patient has high-risk disease and takes sunitinib for 1 year, then the disease may come back a year later. So you take sunitinib for a year, you gain a year. But as the data stands right now, it does not make the patient live longer. And I think that is an important discussion because for a patient, I would assume, the decision to take a treatment and its side effects is probably a lot better if there's a chance, a 20, 30% chance of never having a problem with cancer again, rather than just the knowledge that it may come later. The second point I think patients need to understand is that, as I mentioned in my introduction, that we are not in a position right now to say whether you as an individual patient, whether your cancer is destined to come back or not, aka whether the surgery was enough to keep the cancer away or whether the cancer will come back. So there is this significant chance that a patient will take treatment and its toxicity for a year without really gaining any benefit. And my position is that I'm happy to discuss these things with my patients, but I really want my patients to understand what we are trying to do here and what we are doing before they make a decision, because I think it is not as clear-cut as it is potentially in other tumor situations, for example, in bowel cancer, where I can tell the patient, if you take that treatment, then your chance of cure is 30% higher than without that treatment. That's an easy discussion. Here, it's not that simple.
So again, I actually agree with Christian on most of those points. There's a little nuance on that, though. I think that delaying the onset of the cancer a year is important because things are changing so quickly. And that's what I told my patient, these two patients in particular, and I have a number of patients on adjuvant sunitinib that are not candidates for the trial, is that delaying the onset of the cancer for a year, even though we don't know you'll live longer, is important because things are changing so quickly. And you saw Dr. Canil's presentation about Ipi-Nivo coming in shortly, and things are changing every few months. Every ASCO, GU-ASCO meeting, we have new options. So delaying the onset of the cancer by a year, to me, is a valuable endpoint.
I don't disagree with that, but I think the ultimate decision about the value of this particular endpoint lies with the patient. And I have had this debate with patients, and every patient has a different view on that. Some patients tell me, well, if the drug doesn't make me live longer, then I don't want to have that toxicity right now. I really want to enjoy my time, and I deal with it when it comes back. And other patients say, you know, if I can do anything to prevent that from happening, then I'm happy to try that and take the toxicity. I mean, an important point for patients is also always to understand that if a treatment becomes too toxic, you can always stop it. It may sometimes not come out in discussions with oncologists, but I explicitly tell that all my patients when they say, I don't want to try this or this because of toxicity, one can always try and then try to adjust, and if it really doesn't work, you can stop it.
So exactly right, and I think that the patients I have on adjuvant sunitinib, they do have a lot of side effects from that, and some of them are miserable, more miserable than Christian is. So, you know, so I had to throw that in there. So
That's hard.
So it could be tough, for sure. And if it was no toxicity, it would be a no-brainer. But the toxicity is a significant issue, for sure.
Actually, I'm going to ask you, I'm going to read something from a recent update on the PROSPER trial. And I want your response to it. It's Dr. Lauren Harshman's comments. She's the principal investigator for the PROSPER trial. And she says, in the quote here from the transcript, right now we have no good biomarker in kidney cancer to help say, okay, this person really has a high chance of recurring, even more than we know that by just their higher stage alone. So we hope that not only will we improve cures and outcomes with this approach, but we're also going to really provide quite a platform for discovery, hopefully, of biomarkers that you can say, you know what, this patient actually does need the nivolumab on top of surgery, or this patient doesn't. They're highly cured with just surgery alone, and we don't have to subject them to the toxicities of the therapy. And I would like to have your response to that, because there are a lot of patients that are highly motivated to go on trials. I worked in clinical trials for a number of years, and patients, they find hope in clinical trials. They get better screening, better treatment, because they get monitored more, and they feel, and it's not for everybody, it's for the person who's highly motivated. And when you get biopsies, you get all this tissue that you can examine as secondary data, a patient's tissues, and you can make discoveries. So in light of all of this, what would you say to that?
So just in light of this, I quickly want to clarify the term biomarker, So that's all over every website you have in kidney cancer right now. A biomarker is something which we can measure and it tells us something. For example, a predictive biomarker in a treatment situation I can measure something and then say, this patient has a very high chance to respond to sunitinib, or this patient has a very low chance to respond to sunitinib. So, or this patient has a very high risk of recurrence, or this patient has a very low risk of recurrence. The ideal biomarker would actually give us the decision. So there are biomarkers, for example, in breast cancer, they measure whether breast cancer has a certain feature which is called HER2/neu. If a patient has that, then there's a good chance they respond to a certain drug, trastuzumab. If they don't have it, there is zero chance that they can respond to that drug. So you don't even have to try it. So that's the term biomarker. A clinical trial is something which is very important, and there's a number of reasons why we offer patients clinical trials or why patients accept clinical trials. There are different phases of clinical trials, phase 1, 2, and 3. And participation in a clinical trial is it may offer a patient an additional treatment option. That's one of my most important reasons why I offer patients clinical trials, because it often offers patients something which they otherwise don't have an access to. And keep in mind, if you are offered a phase 2 or phase 3 clinical trial, then the drug already has shown activity. And the question is only how active is it, and is it better than, or is it better than the existing standard therapy? But you are potentially offered an active drug. Even if the trial is negative, and this is a debate which is ongoing in medicine all over, because there's a tendency to underreport negative trials. A negative result of a good clinical trial is an important result, because it tells us you're going into the wrong direction. Don't go there. And then what happens now, and that comes what Pat just read, most of these clinical trials are not only testing 2 drugs or 1 drug or something like that. Virtually every trial in kidney cancer and other tumor types is now structured in a way that the patient allows us to take blood and tissue for research purposes in order to try to find these factors which would later tell us, yes, this patient has a chance or not a chance to benefit from this or this. And that's extremely important, because it would make our life a lot easier. If I can measure something which tells me, yes, the patient has a very good chance to benefit from drug A, but not so much from drug B, then my choice and your choice is a lot easier.